good stuff.
Learn anything new this week? If the answer is no, I don't want to talk to you.
Gosh, it's like, I don't know where to start on that question. Like I learned a lot about some TDECS stuff from Jay Gunkelman, which was fun. Reading about, my head's a little fuzzy because it's been a big week, but reading a lot of HBOT literature, trying to work on the class. No, it just feels like everything's moving forward a little bit. So a little bit faster than average, but everything's moving forward a little bit.
What are the go-to systems for you?
Well, so
okay,
I like
LLMs.
I love neurofeedback, obviously. But within neurofeedback, you have different modalities. So you've got classical neurofeedback, which is sort of like you got SMR style training. Hey, we got Saul. Excellent.
Hey there.
We got him.
We got a party now, baby.
Yeah, that's great.
Yeah, right.
How you doing, Saul?
Good. How you doing, Josh?
Good. We were just talking about different types of neurofeedback modalities and how there's different stuff out there, and sort of the difference between evidence-based stuff that is maybe more in the range of amplitude training and SMR style stuff, and then there's a few other things probably thrown in there.
Mm-hmm.
And then there's all this other modality stuff that has some evidence and is interesting. And then I'm sure that the range of what experimental is, it goes really deep.
Yeah.
So, and I tend to get my hands dirty on everything, but I don't bring it all into my clinic.
Right.
So,
mm-hmm. Well, you got the Titanic submarine going. How's that?
It's off buzzing. You can hear it right now. I got my hard chamber hyperbaric oxygen therapy running in the background. Yeah, it's up there buzzing away. I think we've got 6 people have been using it today. So it's been busy since 7 a.m. I think. So yeah.
Any learning so far? I'm very curious.
Oh gosh, the learning curve on anything like procedurally that's new. It's like you can say, well, I understand hyperbaric oxygen therapy. Maybe I've read 50 studies, and I've gone to the international conferences, and I've met with, dozens and dozens of researchers, and I've hung out at clinics for hundreds of hours. But then when you actually get it, you're like, little things like, oh, what happens when a staff calls out sick? I didn't plan for that. Like, oh, I didn't think about that procedure. Like, you can't not have it. Like, okay, I'm calling out sick from neurofeedback. That's okay. I'll cancel them or reschedule them. You can't do that with HBOT sometimes. They're not allowed to go more than 2 days without a session. And so it's a Monday. You can't call out sick, man. Someone has to show up and do it. So it's like, didn't see that coming. So it's like those little blind spots that you just don't know to think ahead on. And you don't know until you get there that there are different bumps in the road. There are different blind spots. It's got a whole different personality, and the only way you're going to figure it out is by just doing it.
Hey, Lynn's Brain, thanks for hanging with us. How do you explain to clients why the surface maps do not agree with the S-Loretta maps?
Oh, that's fun. That's a spicy question right there. I don't know if Saul are going to have different questions. I'm comfortable, but I'm a big, huge fan of looking at the raw data. And if you can't see it in the raw data, I don't trust it. And so everything else is demonstrative, and this is going to sound a little bit messed up, but some people are like, oh, S-Loretta maps, you've got to have some specialized processing to see some of these things. And it's like, yeah, maybe if you're a beginner, but like you kind of know what you're going to see in the S-Loretta maps in the raw data if you have a lot of experience. And if it's not obvious in the raw data, I'm not going to trust it. So I don't know, Saul, what do you have to add to that?
Oh, no, I totally agree. I mean, I get, I do Loretta. I don't do SW Loretta. I do good old-fashioned Loretta, but just for the cues.
Yeah.
And it doesn't always agree with the EEG, and I will dump it.
Yes.
And stick with the EEG.
Yep, demonstrative. Yeah.
Old-fashioned, but it's still more reliable and valid. So.
Yeah. I actually had all the S-Loretta and all the automated maps and the Z-scores, and my staff kept leaving and starting clinics and not doing raw data analysis. And I got so agitated by it that I just quit using it. I won't let my staff see it. And all of a sudden the problems are gone. So everyone's learning raw data analysis now because they have to. I literally like shortcuts not allowed and that was the only way that I could move forward in my clinic. Maybe somebody with a different temperament or personality could have convinced their employees to learn to do it the hard way, but I wasn't finding success with that. I was finding that they inevitably just took the bait and started a clinic with just Z-score analysis instead of raw data, and I couldn't tolerate watching it any longer.
Yeah, I mean it's very seductive. I mean, and there's a lot of surface validity. I mean, it looks like it's really telling you something, but that's the problem with the EEG in general. It's like unless you know what you're doing, and I don't pretend to know a lot about what I'm doing, and I know where my limits are.
The Dunner effect in real life. Here we are.
Exactly. And that's why I put out questions on the consults and talk to Rusty and other people. So
love Rusty.
Yeah.
Great piano player.
Have you ever met anyone who didn't like Rusty? I would immediately distrust them.
Absolutely. Absolutely.
I want to see dueling pianos with Rusty and somebody else in the neurofeedback world.
What's the guy who does the blues music? Bug me.
Yeah. Oh yeah. I thought he just sang.
Does Dave Sievert play?
He plays the guitar most of the time. Yeah. Right. Don't get me wrong. We could do a band.
They have at their various conferences. They have done that, but not for a few years,
believe
as far as I know. But
got to dance in those dendrites. Yeah.
So I sent out mental health in the news, neurofeedback in the news, and what the algorithms popped up this week was differences in men and women in mental health. Just while we're waiting for everybody else to ask a question, that means that I have to ask a question. And are there any big findings that you all are seeing, especially since we've been making note of the iMedicine Korean database, because they're separating the databases? I don't know if anybody else is. I'm just a video editor here.
I think HBI is as well now.
Okay, great.
I think they have separated.
I'd love to get into database work someday. I'm kind of reaching the point where I'm creating enough free time to do things. And who
is that?
That's the Win EEG, the MITSAR people.
Okay.
I mean, it's split off, but that's where it started.
Cool.
Do you know when they went to genders?
I don't.
I think the Koreans were first, and it wasn't that many years ago.
I think you're right. I think it was after the Koreans did.
And it was mostly because they realized there was a difference mostly in kids and the elderly. It kind of averaged out in the middle and then split again.
Because I know Jay's pointed out that the average, the non-difference is really an average across ages.
Yeah. So I'm not particularly well briefed on the differences in kids. That seems more of a Rusty kind of game. But it's not too hard to understand the differences between men and women who are older, partially because you can see it and you run into it. So it's like once someone tells you that, you're like, oh yeah, I've totally seen those differences between men and women who are like 60 or 70. Men tend to lose power, women tend to gain gamma. And those are the main differences between older men and women in the Z-score, or the changes. It's fascinating. It likely relates to testosterone and the corpus callosum, possibly.
Is that what splits the two hemispheres, or what is that?
Yeah. So when you're a fetus and you're 6 weeks in utero, testosterone, if you're a male, your testosterone glands start kicking on, and the testosterone washes across the hemisphere in between, across the corpus callosum, which is the connecting tissue. It's about, I don't know, is it 2 inches or whatever? It's something like that in the center of the brain. But it's not myelinated. And so the testosterone actually shrinks the corpus callosum in males. And this causes men to sort of have a different interhemispheric relationship than women. I don't know that it's measurable with the naked eye in the EEG, but it does play out across time, and you can also see it sort of in almost personality, where men can hyperfocus more and need time to adjust from problem solving to emotional listening, or vice versa. They need more time to sort of get into a different headspace. Whereas women, by stereotype, and it is just by stereotype because you can have all kinds of variants for all kinds of cool reasons, they tend to be much better at alternating between different hemispheric functions. And but that also comes with distractions. So, so it looks more like personality. It doesn't have a huge functional difference, but it does help people who are like marriage counselors. It helps you understand, what's happening in the room right now.
Right.
Mm-hmm. I was going to ask about that because we've had in the past years counselors who do neurofeedback, and they talk about using neurofeedback in the sessions and the differences between men and women. And I would think that would help out a lot, because if you can point your finger on why something is happening, it kind of takes away like it's your fault,
Well, and in our culture, you kind of have to always give this sort of platitude of, this is like an 80-20 rule. Like anything that you say, you kind of have to constantly remind people this is only true like 80% of the time. Because there are going to be exceptions, and maybe those exceptions are going to feel more alienated if you don't kind of reassure them, like that variance and unusual personality types are fine and normal. And that can be because of just natural temperament, or it can be that this particular man didn't have that testosterone wash until later in development, or this woman did have an excess of testosterone. And there are many studies published on that they thought that was what was going to inform gender dysphoria, but it did not. It just ended up having an impact on personality. And so you'll have like fairly assertive women who are very hyper-focused and need time for adjustments. And then you have, fairly emotionally in tune men who are distractible, something like that is a stereotype. And those were individuals who were identified as having sort of like late testosterone washes or excess testosterone in fetal development. So fascinating studies. They're absolutely wild. And it's cool because of how much it informs personality, but that's all, So.
Hey, Jahan showed up to the party. Hey guys, could you spend a minute to review the phenotypes associated with ADD, ADHD symptoms? Is it different for adult clients? Treatment implications?
It's a tough one. I know that's going to hurt some people's feelings if I say what I think, but I think that every phenotype leans itself towards ADHD, and so if you have a clear phenotype, moving that towards normal will improve your attention. Now, there are exceptions if you have other neuromarkers, but you kind of have to look at what's the Occam's razor, what's the most likely explanation for the dysregulation. And, a large imbalance in any phenotype is probably the cause of attention deficits. So, yeah, ADHD is a construct. We made it up. It's just a box. It's a box we put everything that looks like this in this box. But that box is full of like 15 to 20 different things. So nobody knows this more than Saul. There's lots of protocols that work on ADHD generically, which is amazing at all. That's shocking that works.
Hey, Anthony, say hi to Saul. Saul wants to party with us.
Hey, Saul, it's great to have you. That's awesome.
Thanks. Good to be here.
Saw you were getting some feedback today, I think even from Jay and others on the forums.
Oh, yeah.
What happened?
Oh, I put out a weird, having a kid who's having an adverse reaction to the neurofeedback, nausea.
Yeah, I've seen that.
I was wondering, had some thoughts about why that might be.
That is a little different. Yeah. Well, good luck on that. Hope something comes of it.
Yeah. I think we'll get there.
I don't know. The video editor's throwing stuff out because I don't see anybody asking any questions. But is that something with the occipital back there, or like what's the?
Well, it's not entirely clear. I didn't do the Q, and I haven't been able to get a hold of the data yet, so I don't know what's there.
To be determined.
We're just talking about that, right? But I think I'm probably training. Well, it's interesting because I think that I'm training 12 to 15 up, and I think that's too high. And some people are saying no, that's too low, and some people are saying it's too high, and so and I'm training back in the temporal region, which I suspect is also. Affecting it. So
it's nausea's a tricky one. That one makes me anxious more than any other symptom. I want to move away from it so fast.
Yeah, and it's been very reliable with this kid apparently. Of course, they didn't tell me about it for several weeks, but that's normal.
Josh Jahan obviously wants to know what your protocols are for AD. that you use?
So I think Saul might be able to give some generic protocols that have been shown to have efficacy for the construct of ADHD. My approach is to just train the neuromarkers that in this client present as likely being the responsible party, and there could be 15 different versions. But if there's something more generic, Saul's like the guy.
There are some generics, but I mean, I would just want to, the caveat being, and this really connects with what you were saying, I think anything that affects the brain is going to affect the frontal lobe.
Yes.
So it's it's going to present in some sort of attention dysregulation or some executive function dysregulation. So, and again, it's like you said, it's construct. Brain doesn't care what we call it. It's just wants to get us through the day. And hopefully we'll help it along a little bit with the neurofeedback. There are some sort of generic training. So it would be sort of a CZ or C3 minus C4, trying to inhibit theta, maybe alpha, and enhance the SMR, the 12 to 15. There's also frontal alpha type ADHD. So you might want to try to inhibit alpha in the front. Sometimes C3 to minus A1 or C4 minus A2, and sort of low beta or SMR enhance, and again, trying to reduce, because typically it presents, the dysregulation often presents as slow wave activity. So you want to try to inhibit that to some extent. Sometimes I just do inhibit, sometimes I don't even enhance. Yeah, that's one thing with software. I want better like inhibitory feedback options because I do that too. I end up with a lot of inhibits or all inhibits.
Anthony, could you read part 2 for Lynn?
Lynn has an interesting question. She says, part 2 of my alpha question. I understand alpha blocking, but what's happening when a very normal eyes closed EEG turns into a very small, fast EEG's eyes open? So it sounds like the speed changes as well, which is interesting.
So triple network theory.
Okay.
Yeah. So they have an excess amounts of salience and executive function, which is a non-specific vigilance dysfunction. When you have too much transition into fast content, you lose too much alpha. If you lose more than 75% of your alpha, probably a non-specific vigilance issue. But it's really secondary to something else. So you look at sleep, you look at trauma, you look for other neuromarkers to explain it.
Very interesting.
That's my thoughts. I don't know. Anybody else can contribute? So
I think that makes sense. Usually I'm seeing the opposite problem where alpha doesn't block, because
that I do see, but it's rare. It's fascinating because different regions, I feel like we do get different combinations.
Absolutely. It's totally a Boston area thing. It's because nobody sleeps here. So everybody is sleep deprived.
Well, when my clients are sleep deprived, they're too vigilant when they open their eyes, and then they get drowsy when they close their eyes. So we get tons of alpha unless they're drowsy, and then we get almost no alpha when they open their eyes. And that's kind of what we see on my side of the Mississippi.
That's so funny.
Yeah, and it's really obvious. Like that's the trend. It's like a clear trend.
Oh yeah, no,
Jan has another one in the pizza oven. Could you discuss your recent post about dementia prevention by speeding up the brain?
Oh, I don't remember posting about that, but I mean, the brain, there are types of
dementia.
Yeah. I mean, like there is the brain slowing down is a risk factor, and I believe it's part of the discriminants. Your alpha peak frequency, precipitously slowing down is a really, really big red flag. With the Amen clinics protocol, Dr. Amen talks about how there's usually, at least 3, sometimes 5 global inflammatory causes, and you want to take at least 2 out of the equation, and then you want to do a rehabilitation program. So it's like, okay, we have untreated sleep apnea, we've got gout, we've got diabetes, and we've got, the list goes on. It's like, okay, well, let's resolve a few of those medically so that we've taken pro-inflammatory, global inflammatory stuff off the table. And then you can do things like hyperbaric oxygen therapy and neurofeedback, nutritional therapy. There's some herbal stuff like ginkgo biloba, saffron, etc. And you're going to hit it from a few different angles because you don't know that you've actually controlled for enough of the global inflammation. And then there's another ethical issue. My issue is that when you have somebody who's really far down the dementia path, it's really hit and miss whether they're going to appreciate being brought back. And so you really have to give informed consent because like they can be really brought back and they aren't necessarily going to be happy because they're not going to come back to 100%. And when they're descending down into dementia, they're kind of content to go descending down into dementia. Their family's not, but they're kind of content to do that. But if you bring them back, they're not going to be happy. And that is actually observed in some other types of studies, like coma patients. Jay actually did a study where that was seen in a coma patient study where they were not happy to be brought back. I find the exact same thing with dementia. They're not happy to come back. Not all of them, some are. And so you have to get informed consent. And it's not work that I love doing because of that. You're kind of flipping a coin that they're going to be grateful or angry.
I think I've seen that too. To be honest, Josh, that's a bit of a longer story. Jehan is he was responding to a big study that went out this week that it was a randomized clinical trial that showed over 20 years and 2,800 subjects that showed that a brain training game offered by a company called Brain HQ reduced dementia rates 25%, and specifically it was a game. It was called their speed training, and only their speed training game did it. And essentially, they have to identify 2 points, and the game speeds up. But the interesting thing, Jehan, that I forgot to post in the original post is they found that fast video games like Call of Duty can have the same effect. So you might be able to get some of this without paying extra for it, or if you already gained.
Yeah, what I find is that the problem with some of these, I won't name brands, but the problem with some of these brain training things is that they have to keep you disequilibrated, is the technical word, in order to provide any benefit. So the moment you get good at it, it's useless. The moment you get comfortable, it's useless. Like it has to be mind stimulating, and so it has to be uncomfortable. Like
use it or lose it.
Does that mean like? Does that mean the tech has to keep an eye on the thresholds? The video editor is asking.
So I think they're talking about something that's more like luminosity, where they're just doing puzzles. So not doing any actual brain training. It's not conflation of terms. Some semantics are involved here. They're talking about puzzles.
But it does make you think, and to Josh's earlier point, it does make you think of alpha speed, the alpha peak alpha frequency, or posterior alpha. And I think I've even heard Jay refer to that posterior alpha speed is almost like your sampling rate on reality, or maybe at least visual stimulus, but also memory. I know we talk about. Jehan has an interesting question here that I brought up a week ago too. He says he had a client who sleep onset improved with SMR training. So that I assume that means they went to sleep more quickly. But now they're waking up at 2 to 3 a.m. and can't get back to sleep. And I've actually seen that happen, maybe not 2 to 3 a.m., but I've seen it happen in individuals.
Yeah. So we do naturally have like 2 sleep cycles that we kind of repeat, one for deep and then one for REM. And it's normal to sort of wake up in the middle of that. And sometimes if you need a counterbalance, like the salience network needs to be exercised, the frontal lobe needs a little exercise. Sometimes that's what's getting in the way of you starting your second cycle. So you're waking up halfway through, the process, which is the full first cycle. You're coming, to that super, super shallow sleep where you generally will wake up once. And, your frontal lobe kind of goes into a failure mode and you can't go back to sleep. I think that's sometimes what happens. So sometimes when I see that, I'll add in a frontal midline counterbalance. And sometimes that's the solution. I don't know. Saul, do you have an opinion?
That's actually, so by counterbalance, you mean like if you're doing the CZ, you would do FZ, minus
Correct.
CZ or something like that. And just I do find, and Jay talks a lot about counterbalance as well. This is where I picked it up from.
Me too.
It can be incredibly helpful. Well,
yeah.
Right. It can be really helpful to counterbalance when you're getting a little bit, it's almost like, it's like squishing out one area. So you got to kind of get it.
It is flexibility. You're training flexibility.
Exactly.
So,
Oh, interesting. Flexibility. That's cool.
Hey, Radar's got another one, Anthony.
Let's see. Here we go. Is a QEEG even useful prognostically if the client is taking medications that affect the EEG or that alter the EEG?
Go for it, Saul. I do have thoughts on this, but go for it.
I mean, you can just ask that question in general.
Yeah.
Right? Because lots of things affect the EEG. So what we're looking for is patterns that stick out even though they may be in medication. You want to take into account what medications may be doing, so you want to know what they're on, and well, medications broadly defined, substances, things. Even taking EEG different parts of the day, different times of the day, is going to have an impact. So, yeah, it's inexact.
Well, some of Ronald Swansina's employees are doing daily QEEGs on clients to see how a woman's cycle is affected by the QEEG. It is minimal, like a variability of 10%, but the 10% does tell you some very useful information. It's very fascinating. I would add that medication generally has more of a global effect, and so it doesn't get lost on you. If you're a reasonably trained practitioner, you're not going to miss that it's a medication effect, and that you generally are going to try to memorize, especially the larger influences. And there's only a few EEGs that are ballistic to the data. I would say that medication effects can be quite mild if you're using like an average weight montage, but every now and then there is a med that can be ballistic, like THCs.
But you also you get to see. Eventually you get to recognize that.
Yeah, of course. Yes.
What are you using, and when did you use it?
I think I've even seen Jay say, "Tell your practitioner what you're taking, and that they can maybe screen for that, account for that in the EEG." To be clear.
AI will take care of all that.
I think the effect that I see
like I have job security.
I think one of the effects that I see a lot that I think does make it harder is long-term benzodiazepine use. That's tough to figure out exactly what's what sometimes. But
I've seen people say that you can't train down the benzo buzz, and some people even say that's true even if they're off the benzos. It feels like I've seen it trained down though, but I don't have enough experience to feel confident in that answer. So I was wondering if you had any thoughts on that.
It's a tough one. I don't have a ton of experience with it, but I have worked with some people who've just been on benzos for years and years and years and years. And even some that they've been off it for a while, and you still see that effect. So it's tough.
Do you think that it washes out with the 2-year post-acute withdrawal, or do you think the benzo buzz is more persistent?
No, I think it probably typly does. Again, I don't have that much experience, and there are plenty of people who have a lot more than I do. But I've seen it with people who've been report they have been off of it for more than 2 years and still and still see.
You still see it, That's kind of, you can't be sure sometimes if it's like, oh, how accurate is this information?
Well, exactly.
I used to be a drug and alcohol counselor, and it's a totally different theoretical framework when you're in that game.
You know what's go on.
Go ahead.
You know what's the worst is I have, I think I have several friends at this point. They're adults they have Adderall or stimulant prescriptions, and they are also prescribed benzos to fall asleep at night because of the stimulating medication.
It's like we all worked for MGM Studios back in like the 40s.
Like, uppers and downers.
Uppers, downers.
Man, yeah. Let's see. Jahan asked about benzos. Does the benzo caution refer to the Z drugs like Ambien as well? How long after stopping the medications do both kind of drugs get out of the way? I don't think it's as strong. I don't know if Z drugs have a black box warning, which is what benzos have. It's the FDA's strongest warning, Jahan, I'll just say. But I do know that doctors, at least younger doctors I know, think of them similarly, that Ambien, they don't want you on it chronically either. And then I'll let the other gentleman respond here, both of you.
Yeah, Ambien is related to benzos. I don't think it's quite in the same family, but there's
it's slightly downstream or upstream. It's different.
But we also know it doesn't work in long term, and yet every person I know with insomnia, or every client I work with with insomnia, has been on Ambien for much too long.
Everybody says that anybody can get a prescription, 30 days, 30 pills. That's okay.
Who said?
No,
that's what I hear.
Don't do that with benzos. Jeez.
I don't think they give them out quite that freely, but hopefully they don't. But
you have biochemical changes in the brain at 20 days. So I wouldn't do that with benzos. I wouldn't do that with opioids.
I was talking about Ambien for the people that have problems with sleep. Everybody thinks that it's okay, and it's not. And then the other thing is on the benzos. Isn't the hard part about those things is getting off of them, and how do you use neurofeedback to help you wean yourself off of that?
That's one of the hardest things you run into as a provider. You don't just have withdrawal from benzos. You have a rare thing called post-acute withdrawal syndrome, and a lot of people do not know what that is. But post-acute withdrawal syndrome is a dull ache anxiety that will gnaw at you for a year to 2 years. And you have that with a few different medications. I forgot the opioid replacement one. I always forget the name of it though. Methadone. You have it with methadone, and you have it with benzos, and it will kick your butt for more than a year. And that is a high interest rate on a medication. Usually we prefer our medications with a reasonable payback and a low interest rate. Benzos and methadone, very aggressive interest rate. You will pay for that like a bad bank loan.
Usually for sleep these days, what I hear younger medical professionals recommend is trazodone, because it's the only medication they have that doesn't seem to harm sleep architecture, which is your staging. It doesn't seem to reduce any of the stages. However, many people report that it makes you groggy the next day because it's essentially a very strong antihistamine is how it's exerting that effect. But yeah, I don't hear, I know younger clinicians, and they never want to prescribe benzos, certainly not for sleep, and even Ambien. Again, they're edging towards trazodone.
I've seen a lot of Facebook ads promoting the ketamine pill. Is there such a thing? I'm just throwing it out there because I'm waiting for another question to come in.
Ketamine pill? What about ketamine?
Instead of going in for the IV, they say you can take a pill for it. Obviously, it's a face.
There's no FDA approved, according to Google. So that's
okay.
That's funny if they can advertise that on Facebook. That's a little surprising. Go on, Josh.
No, the advertising thing needs to be talked about. Geez. There's a lot of problems with letting these medical companies advertise because it influences what these media companies will censor, and it will influence what these media companies will do articles on. So if you're getting money from these drugs, you're not going to write hit pieces on them. And so that's the main concern with advertising. It's not that it's in your face. It's that it's money that satiates these information hubs, that it actually influences how these information hubs behave around these systems. And in some cases, that's the motivation for why they keep putting money into it. Maybe you're going to see this drug on the TV, but that's not necessarily why that drug is on the TV. It's there sometimes to satisfy the media company into not writing a hit piece on them in a way. And it's not a quid pro quo. It's more subtle and more long-term and more strategic than that. It's just part of the game. But it is influence in the end. It does have a subtle influence, and it's money well spent when you look at it from a bird's eye view. And so we do need to think about that in terms of regulation.
Yeah, Jahan mentioned there is a ketamine nasal spray.
Spravato.
Okay, Spravato sounds like okay. And then
okay.
I'm not sure what the side effects. I'm going to my ketamine notes. I will say on benzos. So Radar also echoes that he's heard it can be very hard. And, there's somebody famous who's going through benzo withdrawal right now, still like 4 years later, Jordan Peterson. He was hospitalized. He was put into a medically induced coma. He had to go to a clinic in Russia. But now even a year or two after that, he's back, and his daughter had to just put up. And I just kind of followed them casually. They come up in my YouTube.
I was actually going to meet him. I had a meet and greet plan with him, and I missed it because he got ill. So
he was only on it for 2 years. And, he said what I thought was a minimal dose, but it was like 2 milligrams. So it was not the starter dose, let's say.
No.
But 2 years, and so he's suffering from this 4 years later.
And I'm kind of sympathetic how people get into this because his wife was terminally ill. She obviously
had a lot of anxiety over that. Yes.
Well, I don't, as a therapist, I try to be empathetic and understanding. Like,
sure,
if my wife was dying, and I had an immense amount of responsibility on my shoulders, would I take the meds? I'd like to think I'd be more responsible, but that's naive.
Right.
No, there before the grace of God, it's the famous thing. So,
yeah,
I get it. I get it. I say that more just to warn and inform people that it's.
Yeah. Totally. Yeah.
It can be serious.
That I'm sure he wished he hadn't.
Yeah. I know, right? And Jay,
yeah, go ahead.
He's asking about what protocols. Let's see. I think he's asking about benzo withdrawal protocols. I'm guessing it's the benzo bump, the 22 to 30 hertz. What do you guys think?
17 hertz.
Yeah.
17.
Yeah.
Okay. And
so, I mean, there's a few ways of looking at this. I'm sure the classic protocol is sort of GABAergic SMR style. That's how you get some extra GABA production is SMR, and then try to suppress the benzo buzz, which some people say won't work, but I've seen it work, so I think it works. I don't know if it's the SMR that's suppressing it or the suppression protocol, but I think I'm going to do it anyways. The other thing I do is I will do things like infraslow, that I find that some of these neocortical potential trainings are quite calming to these individuals, and they will say it takes the edge off by 10 to 20%, and they'll say that very quickly after a session or two. And anything that does a 10 to 20% dent on a benzo withdrawal is an impressive tool you want to keep in the toolbox. And that's anecdotal. That's not published. I don't know if there's any published case studies on it, but I've tried things with these very, very miserable people, and you don't forget what works. It sticks in your brain.
Yeah, Radar has said. I think he said this before too. He said he's heard that low alpha people have increased GABA. That's not something I don't think I've come across that. I thought it was higher. Like for instance, I think benzos can acutely raise alpha, but I could be incorrect there.
Yeah, you're correct.
So yeah, and then
how they measured the efficacy of pharma GABA was they measured if it increased alpha.
Oh, wow. Okay.
Yeah.
Yes. He says that comes from the big man himself. I'm guessing Jay. So, okay, I'll have to ask what Jay, how that works. I was going to say, and I personally know an individual who's gone through benzo withdrawal, and it was pretty, I don't want to say catastrophic, but it was, their life was put on pause. Now, fortunately, they've recovered, and it was kind of a dramatic recovery. So that can also happen for them. But, and their friends and family during that whole period were like, I don't understand what's going on with them. And they're so depressed, and I just don't get it. Why doesn't he just...
So long.
And I had to be the one telling, no, when you use that medication, this is a known potential outcome. And fortunately, he's out of it, and he's like a different person. But I say that so people know how dramatic it can be, unfortunately.
Yeah.
Yeah.
Radar says when
I trained up low alpha, it felt identical to taking a high dose of phenibut, which is I know that's a GABA B agonist.
Yeah, that makes sense.
So maybe Radar might distinguish between like a short-term effect and a long-term effect. That might be something like a training effect. Perhaps those could be inversely correlated. So just to keep an eye on something like that.
Yeah. And I find that in Ruth Landis' protocol, like the alpha reset protocol, you can always train alpha down, and it seems to just reorient the whole system. It's a very, very forgiving protocol. People are like, oh, don't train alpha down. It's like, it doesn't really do that. It's fine. It's like when you push water down on a waterbed, you're not actually lowering the water. It's just going to slosh around.
I see what Radar means. He doesn't mean like low voltage alpha. He means 8 to 10.
Yes, that's right. I get it now. You're right.
Low voltage fast low GABA. That's more what I thought. Yeah, Radar.
We're all in agreement.
Sorry about that. Misunderstood there.
Yeah.
Slow
Radar. I was like, I don't know if Radar's right about that. Maybe he was right.
But it's an interesting point. So thank you, Radar.
I do know that the slower alpha will do that.
Did you guys see the study? A guy testified to Congress recently. He's like an education researcher and a neuroscientist, and he said this is the first generation based on NEAP data, government data, that is less smart than the previous generation in every or multiple dimensions of cognitive performance. He gave them memory and attention and speed of thought, etc. So, and he thinks it's phones.
Phones. That's a fair argument. That's a very fair argument. Yeah. Rusty would agree.
Oh yeah, he would. Well, so
I've
would Eric Pepper
before, but so we're gonna pull it up here. I gotta unlock it.
Mm-hmm.
I've showed some of you this before, but my phone is actually an e-ink phone. Like it's an Android, but it doesn't have LEDs. Like it's just an e-ink phone. It has all the regular apps because I have to. With the businessman, you need authenticator apps and you need all kinds of things. And so, but I took this seriously. Hanging out with Rusty too long. Of course,
you turn.
The EMFs, but the best I can do is the LEDs. Martine Arns would be proud, at least.
Yes.
I'm going to ask you about that, Joshua.
Mm-hmm.
Jan wants to know, could you distinguish training up alpha versus regular old alpha theta training? When would you do which?
There's actually 3 protocols. You could do alpha down, you could do alpha up, or you could do alpha theta.
Yeah.
And there are lots of reasons why you would do one over the other. Do you think that's all?
Well, prior to alpha theta training, there was just alpha up, and it had the same impact. And you could do, like you're saying, alpha down, and it can have the same impact. So alpha seems to be a stretchy kind of thing.
Yes. Yeah.
But the alpha theta, you're really trying to push theta above alpha to cross over.
Yeah.
For periods of time, which seems to be hypnotic-like.
Yeah.
And so that seems to be useful for a variety of things, for trauma, things like that. Yeah.
I've always observed that alpha theta seem to cause people to integrate their trauma into their life and lower the reactivity and hypervigilance, whereas the purely alpha-based protocol caused them to decouple from their trauma. It was a very different, like almost philosophical change. Both of them lowered hypervigilance and arousal and reactivity, but only the alpha theta seemed to cause integration. There wasn't an obvious, clear benefit in the integration over the decoupling, except that it was described as more cathartic if they could tolerate it.
Right. That's sometimes the problem. Can you tolerate it? Yeah, and I think, isn't it the alpha down that is used for dissociation?
Sure. Yeah. No, it's very, very powerful for dissociation. I would say I found a lot of use in alpha theta too, but you get more drama. You need more background of talk therapy, and you need a more stable phenotype too. So if you have an unstable phenotype, you'll get less drama with alpha down. Not no drama, but just less drama.
Josh, while we're waiting for a question, that means Pete gets to ask one and has nothing to do with neurofeedback. That phone, I'm trying to get off the Apple schneid, and I'm looking at it, a cheapy Motorola, $150 5G. What do you got there?
So there's only a few e-ink phones out, but I suspect it's going to get more popular. This is a Big Me brand phone, so it's like a Big Me, and it does play video. Like I can play Netflix on it just fine, and it'll just be black and white, so it's kind of comedic. I'm gonna put something on here. Like you can see, it's gonna turn on Paramount, for example. It'll play, and it'll have a decent refresh rate of 33 hertz supposedly. I think it was like $380 for the phone, and it runs fine. There's a little bit of a learning curve because sometimes you have to program the app to have a certain kind of refresh mode. So different for video versus like high contrast stuff. But it's not an intolerable learning curve. I found that I can answer text messages, I can reply to emails before bed, and it doesn't agitate my, somewhat autistic brain into not being able to sleep.
I've even heard of people setting their iPhone or smartphone to black and white, Pete, to get rid of some of the inducement there. Yeah.
I think it's halfway there, but you just need to get rid of the LEDs.
Yeah, I hear that too. And we have one question from Jay Hum, but before I do that, I was going to say, I wonder if some of the cognitive decline in Gen Z is maybe not like directly due to the phone, but the fact that they're up all night on it, as we always talk about. Because in other words, if they were doing anything else keeping them up all night, it wouldn't be great either. And there was a study that came out in the past month, last thing, that they're losing a day or a night of sleep per week. They're losing 8 hours per week. So,
Do you remember Gamer Brain? The part of the Neuro podcast you did? basically the summary of that podcast, and people should go back and watch that if they want to, but it's like once you get to 2.5 hours of video game time, it's as much damage to your circadian rhythm as binge drinking. It's like, oh, we're just gonna let kids do that. Yeah.
Oh,
like,
wow.
Great. Yeah.
Radar's question was, since I promised to answer, he says, well, we're on alpha. Any thoughts on intense alpha training like 40 years of Zen or the older version?
That's before my time, but I do know, I hear a lot of stories on it. But Saul, is that more your wheelhouse?
Not really. No, that's
okay.
Yeah, I'm not really sure.
I hear a lot of people talking about it, but I feel hesitant to try to reiterate it because it was before my time.
Yeah, it's been a long time since I've looked at it.
Yeah. I know you gotta be Jay's age to know a lot more about that and have active
and have his
like,
memory.
experience.
You gotta have his memory.
Yeah,
too.
you have his memory too, right? So maybe if we were there, it wouldn't matter.
Exactly.
Yeah. Sorry, I do apologize not having a confident answer. I feel hesitant to answer having not been around during the period.
Well, the beautiful thing about this Q&A is that we do a Thursday show tomorrow, which everybody in the panel is obviously welcome to join. That we pick on something here that, only the Jay Gunkelman can put his stamp on it. That he'll address things that we talk about here. Dr. Marie shows up. So, and if we miss anybody's questions, Pete at neuronoodle.com. Say, hey, Pete, wasn't able to hang out with you. Here's my question. Or if you want to see a future Q&A, you can go. They're all listed on YouTube in there. I believe you can go in there in the chat and ask your question there, and then it'll pop up, and then we can answer it, and you don't have to show up. But we would like you to show up. We just want to make sure we don't miss anybody. Okay, Radar says, Anthony.
Yeah. In my opinion, video games are completely different from social media or short videos like TikTok or YouTube. Hopefully that's not confirmation bias going on there, Radar, but maybe Jonathan Haidt, actually, he did the Anxious Generation book. He's a psychologist.
Right.
And he said, so his original writing said that games might be different and that games are mostly boys and that they seem to preserve some kind of, they don't seem to have some of the depressive effects that Instagram or social media does. In a more recent podcast, like in the last 6 months, I've heard him say that he originally thought games might be better, but he's now thinking it might be just as bad. Surely there's going to be differences, though. What do you guys think?
Different bad.
Yeah, different bad.
Well, Radar has thoughts.
What is standing out to you, or what are you? He says video games require sustained focus. I could maybe see it. What'd you say?
Video games are a feedback loop.
A feedback loop.
Yeah. Okay. So if I watch a TV show, there's this kind of like disconnection between me and my reality and the reality that that I'm experiencing through the TV. But when I engage in a video game, there's a stable feedback loop between me and the content. And so my brain is more engaged in the content because I'm a participant. Right. And that's why you have such a strong level of response to it versus television. I'm not saying that television is completely and totally forgiving at all, but video games are far less forgiving than television because it's a feedback loop.
Now there is research showing, like Radar's saying, video games you do improve attention and processing speed. However, that's if you're not doing them 2.5 hours a day,
right?
Because then you get into other problems.
Yeah. It sounds like the poison is in the dose, is the famous saying to some degree.
Before video games, it was comic books that messed up our youth's heads. Does like Call of Duty, does that desensitize you to violence and all that? Just
the military used to think so.
Well, you're right. They do.
Really?
Yeah, they used to put people on Doom back when Doom was like the most violent thing. They'd make soldiers play Doom.
Wow.
Yeah.
The research is really mixed.
I'm sure. And there's the psychological element of it. If you think it's desensitizing you, then that becomes the psychological prompt. So it doesn't even matter if it did,
Again, I suspect there's a dose effect.
Yeah.
So if you're playing hours and hours every day, it probably does desensitize.
Yeah. Syndrome.
What's in
Radar? What is Dark Souls? Or do I even want to know?
It's a notoriously difficult video game.
Yeah.
Fantasy game.
That's
not
not
your tongue stuck to play that game.
Because you're threatened? Is that why he's saying that?
No.
You
You have to have a ridiculous focus. Like you have to be logged on in order to play that video
apparently.
game. So like a normal flexible brain is not going to like Dark Souls. Like you're incentivized to be locked on.
I had a friend who was a computer programmer who beat the first Dark Souls, and he said, yeah, once you beat that, you can't play any other game. And I was like, why? He's like, because you beat your head against the wall for months trying to beat it, that when you finally do, it's such a rush that nothing can compare. So I think that rush is why they get.
Did you ever see those React videos to Getting Over It?
No, what's that?
I would go on YouTube and look up Getting Over It React videos, and it's this weird, bizarre game where you're just a man in a pot who has to climb up this impossible ladder that takes you hours and hours, and if you screw up, you fall all the way back to the beginning. It's complete permadeath. It's terrible. But some people get to the very, very end, and it's this very emotional, cathartic ending that ends with you going to a chat room where you get to share and talk about overcoming hard things in life. And it's a really like maximized catharsis. But people had to work for sometimes months to get into that chat room.
Wow, that sounds useful. So Lynn and Jahan had questions, but I think that's a cool use of a video game if it's causing you to talk about things. And their questions, Jahan, they're both about alpha, and Jahan says, ever hear of people training alpha up with both eyes open and eyes closed? And then Lynn asks, would 1 hour of alpha training get someone with really low alpha going?
Yeah, so if you have low alpha, you can train it up. We do that with low power maps, but we sometimes do alpha theta with low power maps too. Low voltage fast as well. So there are some phenotypes where training alpha up is indicated, and you can do that eyes closed, but you can do that eyes open if they're drowsy. The answer is yeah, sometimes, context specific.
You're doing it with the low voltage fast and not the low voltage slow, or?
So I'm going to train the fast content down. I'm going to train the alpha up. Yeah. So I've got my gene 4 variant genetic alcoholic anxiety insomnia case. I'm going to train fast content down. I'm going to train alpha up.
Okay.
And they respond really well to that. I mean, they are going to love you.
That's awesome. And then Jahan's question about, I've heard people training alpha up with eyes open and eyes closed. How do you guys feel about that?
Case specific.
Yeah.
Depends.
Yeah. There are some people it's a terrible idea, but if you're dealing with a low power, if you're dealing with a low voltage fast, some of those cases you can get away with it.
Which part is the more terrible, you think, the open or the closed?
So you don't want to if someone doesn't have an alpha deficiency, you don't really want to train it up in the eyes open.
Right.
I mean, generally, as Saul said, he tends to see people who have too much default mode network in the eyes open. And I don't want to encourage that. Does that make sense? Because that gets weird.
Okay. That makes sense. And
you get weird problems.
And Radar has the topic of the night maybe is what might be going on in the brain of someone with frequent nausea.
So Saul, you were talking about that, and someone mentioned the insula. I thought that was very insightful.
I think that's what I'm wondering, because I was training T5 minus T6. I'm wondering if there's insula involvement in this client who's feeling nausea.
Right insula, posterior?
Yeah, exactly. So this kid also has a lot of diffuse delta and theta, which is kind of odd. But I also wonder if I'm disrupting that a little bit too quickly.
Okay. Yeah, maybe slow. Do you think it could be vascular ischemic?
There's no other symptoms, no medical, no migraine, no.
But you don't have the Q data yet, or do you?
Q data yet.
Okay, so you can't even answer. Okay.
Right.
Yeah.
Right. So
now you're looking at the flow edge of alpha, because sometimes they can't tolerate a lot of SMR if they have vascular.
I think there's something there. I mean, again, there's no overt symptom that would be related to it. But
can neurofeedback?
I bought an inkbot system, by the way. I like my get out of jail free card.
Yeah.
So can neurofeedback replace Dramamine or Mezcal or whatever that drug is for seasickness?
It can if it can.
But is that what's going on with seasickness? Like, what does if you
Is that vestibular?
Yeah.
What was that?
It's vestibular, though, isn't it?
Yeah.
Seasickness.
Yeah. It can be an instability, but
Yeah.
but it's vestibular. Yeah. But it can be an instability.
Is that because I'm the video editor on the show? Is that the crystals in the ear messing with you, or what is the vestibular?
Yeah, I mean, with the inner ear. Yeah, it could be the crystals. It could be something like that.
Sometimes those crystals will get like little calcium burrs, and they're more prone to vertigo. I've seen clients that'll have that without being seasick, and they'll just get seasick walking around, and they're not happy with that. And a lot of times your game is not to fix the vertigo. Your game is to lower their anxiety about the vertigo.
Right. There's specific types of PT for that, physical therapy for that, which is unpleasant, but very effective.
It does work. Yeah. I like doing the neurofeedback alongside the PT because we're trying to essentially raise their distress tolerance with the neurofeedback, and then hopefully the PT will give them the tools to essentially correct and stop the vertigo, because they do have these weird little head exercises they do to stop it. I don't really understand it all, but they do it.
So I recently had somebody go through vertigo close to me, and I'll tell you, so antihistamines help with nausea and vertigo, and calcium. Actually, there was a Journal of American Medical Association. Calcium supplements can help. Of course, if you don't know where this is coming from, and it's not just coming from neurofeedback sessions, hopefully you get evaluated to make sure you're screening for, non EEG specific causes of the vertigo there of radar. And the MD I know also said something. They said, is it vertigo? Is it nausea, or is it also vertigo? Is the room spinning? Because if the room is spinning, that means it's neurologic, he says. That's not.
That's interesting.
Your gut.
I would have guessed that because neurologic.
Yeah, so that's interesting.
The inner ear will give you the same tire, like when you're spinning on the tire swing, you stop it suddenly, you get that spinning sensation. That's all inner ear driven. That's not neurological.
Yeah.
So I don't know.
That's what I thought.
Maybe he doesn't distinguish. Well, I guess the inner ear that's not neurological as well, though. It's not nerves that are maybe.
It depends on what you define as neurological, I suppose. Maybe we're into semantics here.
Maybe he means brain. But I'll tell you, so the physical therapist, I had a friend years ago, they had nausea, and the physical therapist it's called the Epley maneuver, and you can Google it. And it's they lean you over a bench, essentially, to have you tilt your head and hold it there at a special angle, and that resets the calcium crystals in the inner ear. That's kind of like established protocol. The other thing is, I was at physical therapy for like a shoulder one time, and I noticed they had these little bullseyes in front of all the treadmills. And I said, what's that for? They said, for patients with vertigo, nausea, we have them look at those bullseyes while they're walking, and we progressively move their vision so they're turning their head more and more while they're walking. Because motion sickness is the difference between where you're going and so they get acclimated. But definitely, if you don't know where the nausea is coming from, certainly neurofeedback, if you're doing it and you're getting it right after neurofeedback, that's less alarming, maybe. But obviously get screened if you're worried about anything, Radar, or your friend or whoever it is.
Sure. Yeah.
And Radar says, "What training LZ helped vertigo?" And I don't know.
IZ.
IZ, Inyon or whatever.
Yeah. Affective division. I don't know. I don't do a lot of IZ research or reading. Like, I know that there's some protocols by, I think Sieber and Fishers does some IZ protocols.
Yeah. She does. But I don't do much of that either.
Yeah.
Well, we're towards the end of the show where we want to repay our panel for showing up. Saul, I'm in the Northeast, specifically Philadelphia. You got any good neurofeedback businesses to check out?
In Philadelphia? Sadar Psychological. They're right outside of Philly.
Okay.
I grew up in Philly.
And are there any good associations in the Northeast that I may want to check?
Oh, there is perhaps the Northeast Region Biofeedback Society, nrbs.org.
Great place to go.
And it's not just for professionals; it's also for anybody who's interested.
And we're sorry about the Patriots if you were a fan there, Saul.
Well, it was not surprising.
Washington.
But then we go to Joshua. On the other end of the country, I'm in Washington, Northern Oregon, whatever. and I got to get some pressure breathing chamber work. What is that called?
Hyperbaric oxygen therapy. Yeah.
Thank you.
It's our new project that we're sorting out this week.
And how do I get more details on that, Joshua?
I mean, you can go to Alternative Behavioral Therapy's website, neurofeedbackcare.com. We also have training courses that we're slowly rolling out on phenotypes. We're doing like a comprehensive review of phenotypes one by one at qegcourses.com. It's going really, really well. We've got a ton of mentoring groups built out. So like one thing I didn't expect was the amount of subscribers who would immediately want to just do regular groups. So like, I guess this is who I am now. So I guess that was fast.
That's great.
But I do love it. So I'm not upset.
It's great because I think you're doing like you're replicating Jay to some extent here. I think.
I wanted to build out some like formulate classes that are well produced with like green screens and visual graphics with good slides that are about 3 to 4 hours of content for each phenotype. So we're looking at 40 hours at least for the whole set of phenotypes. And they do have like a base template built, and it is going to be about 40 hours, maybe 50 hours of content for the phenotype model. But it does go over things like, primary protocols, evidence-based protocols, literature review, other protocols that might be useful. We usually go over TDCS and TMS, and then other types of therapies that might be useful for referral. So we're trying to go for like a sort of a bird's eye view, but comprehensive. And then it's encouraged to follow up with mentoring with somebody. And that went well because people are reaching out to me. And so that encouragement apparently did land. I wasn't expecting them all to come to me, but I'm fine with that if they want to.
Well, everybody wants to be BCIA certified, and you need a mentor on that. And I don't know what your guys' hours are or you're looking for, but joining these groups, the Northeast group, Josh's, whatever, and then Anthony's group would be a good place to connect with somebody to help you out. Like what groups, Anthony?
Yeah. I mean, Jahan, it sounds like you saw the Brainmaster group posts, and those aren't brand specific posts. It's just a cool group, and science and technology discoveries. And there was one other quick thing about this week that came out. A study came out, I'm sure Lisa Tatterin really loves, which is some university found, they believe they identified the cause of Parkinson's, and they said it is, they literally said it's like 20 to 35 hertz brain waves in the subthalamic nucleus of the somatosensory cortex. And I know Lisa, I've heard her say, I don't know if she said this at her presentation, but I've heard her say kind of off the record, SMR is a great training. And that's what we use, or in neurofeedback uses often to treat the thalamus. So it was pretty cool validation in my opinion.
Lisa Tyler,
we haven't great yet to use neurofeedback, I don't think, but they will, hopefully. So that's the kind of stuff we talk about. Yeah.
Send me that link. I want to put that in there, Anthony. It's an awesome call. Saul, Joshua, Anthony, Christopher, Radar, Jahan, Lynn, cast of dozens that showed up for the show. Thank you for hanging out. If we missed you, I'm going to meet with Jay tomorrow, or whoever shows up for the Thursday show. If we didn't get to what you want us to talk about, pete@neuronoodle.com. Shoot me that email, and then I'll go over it with Jay tomorrow. Everybody, have a great night. Get some sleep out there. No more Fortnite, Anthony.
Bye,
Bye, guys.
Thank you.
Bye.